welcome everyone. My name's Kevin Koppes, and I'm the Executive Director for the Epilepsy Foundation, Washington, Oregon, Alaska, and Montana regions. November is Epilepsy Awareness Month, so we have been doing a conference annually for, I want to say, over 30 years or so now. Really nice to be back in person. We did this virtually for obviously the past 2 years. This year we're doing kind of a blend of both. We're back in person, but we're also streaming it live, and we've got folks from Oregon. I saw folks from California that signed up for this. So we've got folks from all over. So that's really exciting. And I do want to start by recognizing and thanking some folks, especially Dr. Novotny, who's out here. Dr. Novotny is the head of the epilepsy program here at Children's. He also is on a couple of our boards, specifically chairs the medical advisory board that the Epilepsy Foundation has here. And we've got folks from Spokane, Central Washington on that board, and lots of docs here in the Seattle area. And then also want to thank these folks. How timely is that this came up here. These are our sponsors that have kind of helped underwrite all of the costs associated with this event, which makes it free for us and for all of you to attend. A couple of final things before we get started here. Lisa, I saw Lisa, there she is. Lisa will be signing off on, I know some school nurses here, Lisa will sign off on any clock hours. So there she is, and you can coordinate with her. And then with that, I'm gonna go ahead and introduce our first speaker, who is Steve White. And Steve will be talking about community pharmacists and epilepsy population health today. Dr. White graduated with a BS degree in pharmacy and an MS degree in pharmacology from the ISU College of Pharmacy. He then received his Ph.D. in pharmacology from the University of Utah. Dr. White joined the faculty at the Department of Pharmacology and Toxicology at the University of Utah and rose to the rank of professor in 2001. Dr. White has been actively engaged in the discovery and development of novel therapeutics for the treatment of epilepsy for almost 40 years. Between October 2001 and December 2005, he served as the principal investigator and director of the NIH-sponsored anti-convulsant drug development program at Utah. Since 1975, this program has evaluated over 32,000 investigational drugs in the in vivo and in vitro models employed by this program, contributed to the preclinical development of many of the new anti-seizure drugs for the treatment of epilepsy that have come to the market since 1993. After almost 35 years at the University of Utah, Dr. White relocated to Seattle as professor and chair of the Department of Pharmacy in the School of Pharmacy. He currently serves as a professor of pharmacy. Dr. White is working on a new initiative with the colleagues at University of Washington and UCB Pharma to establish a community pharmacist initiative that aims to actively engage the community pharmacists in the care and treatment of patients with epilepsy. Please welcome Dr. White.
Thank you very much, Kevin, and thank you for the opportunity to be here to sort of talk to you about this new initiative that we're excited about, and the collaboration that we have not only with UCB, but the Population Health Initiative here at the University of Washington. So our goal with this program really is to develop and try to test a community pharmacist integrated population health program for persons living with epilepsy and their caregivers. And the initial launch of this will be largely in the adult population, but the pediatric population is certainly something in the future and for consideration. As I mentioned, this is a collaborative process. We have been in partnership now with UCB for about 2.5 years in the development of this initiative. And as all of you, I'm sure, know, UCB is a global biopharma company. They have several anti-seizure medicines on the market, including Keppra, Vimpat, brivaracetam, and a rescue medicine as well, Nasalam. And the School of Pharmacy, part of what attracted me to University of Washington and why I left Utah was the epilepsy research that goes on here, not only in the school, but also across the University of Washington. Bar none, I think, at a clinical and a basic level, epilepsy research is really, really strong in the Pacific Northwest and led by folks like Mark Holmes, who's in the audience with us, and Rusty Novotny and others here. And so I was excited about the opportunity to potentially work closer with these folks. And I'll tell you in a moment how we sort of got to where we're at and why we're doing what we're doing. But I just mentioned Dr. Novotny. He is part of the team. Jenny Bocci, who couldn't be here today, but one of our collaborators, Dr. Michelle Ganay, is here today. And either of us can or any of us can take questions or answers. And then others on the UW team include Andy Strigachis and Sabra Zara and let's see, on the UCB team, I don't see Grant or Lawford, Chris, or Derek, but they have been actively engaged in this project really since its inception. So why epilepsy? I probably don't have to say this to this crowd. I mean, it's one of the most common neurological diseases or conditions. 3.5 million people across the United States and 75,000 people in Washington live with epilepsy. And, you know, it's, as you all know, it's not just about the seizures. Oftentimes there's epilepsy-related comorbidities, the anxiety and depression, cognitive decline that takes place over years. And, you know, the principal mode of therapy for those that may not be eligible for surgical procedures is largely pharmacological. And that carries with it, as most know, not only the burden of side effects or adverse events and idiosyncratic events, but also the drugs themselves can worsen the comorbidities. But many patients, particularly adult patients, as they age, they're often taking many other drugs for different conditions. And I can't believe how much of a consumer of pharmaceuticals I have become over the last 10 years. And, you know, just as I age and my body changes and my needs change. But I think the other important thing here is that patients with epilepsy, experience fragmented and sometimes uncoordinated health care and access to community services. And that's one of the things that, you know, we hope that the pharmacists can help to serve as an advocate and a resource for the patient and the caregivers. So that point, I have, as was mentioned, my training, undergraduate training was in pharmacy. I really haven't practiced in the field of pharmacy for years, decades, if you will, and it'd be dangerous behind the counter at this point. But, I have long felt over the course of my career that the community pharmacist is an underutilized resource when it comes to managing patients with epilepsy and other chronic disease states. Many of you, I am sure, have interacted with pharmacists in the clinics. They play an integral role on the team within the hospital setting and a clinical setting, but the community pharmacist has not been engaged, I think, to the fullest level that we think is possible. They are, any of you who have a community pharmacist that you routinely go to, find your pharmacist as a trusted member of the community. I certainly interact with mine quite often, and they are trained, particularly today with the entry-level degree for the PharmD students is a Doctor of Pharmacy degree, and have extensive training in disease state management and pharmacotherapy of various diseases. But I think importantly, most population lives very close to a community pharmacy, within 5 miles, if not closer, particularly in an urban area. Patients, I certainly know myself, I visit my pharmacy more frequently than I visit my primary care providers. And, I find it beneficial that the community pharmacy is open at hours much longer during the week, but also on weekends, and I have access to their expertise. So why Washington? Why are we thinking about this for Washington State? And this was another reason that really attracted me to the University of Washington and the state in and of itself. In May of 2015, the governor signed into legislation State Bill 5557, which actually acknowledges the expertise of the pharmacists and provided them with provider status. So what does that mean? That means that the community pharmacists and the pharmacists working in clinics can actually bill using standard codes for services and consultative services to the patient and the caregiver. And that was huge because for an initiative like this to work and be sustainable, it is going to require the ability to bill for services. They cannot do this in the course of their regular hours. You go into most pharmacies, I mean, they're, as you know, understaffed like a lot of places, particularly right now, and overwhelmed, filling anywhere from 400 to 600 prescriptions a day and unlimited staff. So in order to be able to do this, it is going to take a concentrated effort of the clinical pharmacists in a community setting, working with patients in a very concentrated and intentional way. And this provider status bill provides that opportunity for them to develop a new model to allow the community pharmacists to practice at the top of their license. And that's what we're particularly excited about. So our unifying vision as a team really is to develop a program that will lead to better outcomes for people living with epilepsy. By developing a relationship not only with the patient, but also with the caregivers and the providers, and serving as an integral part of the healthcare team. And over the course of the last 2 years, we've learned a lot. About what the need is, what patients need, what providers would like to see in this kind of a partnership. And we hope that one of the things is that they'll be able to help, fill a gap, if you will, and address some of the breakpoints in epilepsy care that patients and caregivers often feel. As all of you know, living with epilepsy or any chronic disease is a 24/7 adventure. And for everyone, and oftentimes we as patients don't have the place to turn when we need it the most. And to find out about how drugs work, what are the anticipated adverse effects or side effects associated with the new medicine, and even things about what is epilepsy. For the newly diagnosed patient with epilepsy, trying to understand that and is often a big challenge. And being able to serve as a resource, if you will, from an educational perspective, I think is going to be an important aspect of what we hope to achieve with this. And having the community pharmacist who is accessible, with the expertise required, and ability to be contacted at pretty much around the clock, it'll be an important aspect of this program. So this has been a journey. COVID has sort of slowed things down for us, to say the least. Over the course of, we really are probably about 18 months, 24 months behind where we wanted to be today because of COVID. But it started really with doing a literature review, seeing what was published out there with regard to how pharmacists, particularly community pharmacists, were interacting with patients with epilepsy and their families. And what the potential opportunity might be. And that opportunity was identified, if you will, through a series of extensive stakeholder interviews in which, we interviewed patients, caregivers, providers, pharmacists, and really sort of described the program, but also had a series of questions about how they utilize their current pharmacy services and obtain pharmaceutical care, and what would they want to see come out of an initiative like this? What was important to them and to their family? We then worked together to develop some prototypes, if you will, of patient profiles. We had the patient with a newly diagnosed epilepsy. We developed a profile around the patient who actually has had epilepsy for a while and pretty well controlled, but at a point in her particular life where she was considering family and getting pregnant, and all of that takes on a whole different dimension, if you will, when it comes to not only managing seizures, but also managing the drugs during pregnancy, and the potential for teratogenicity. And so, we're thinking about this from a holistic perspective of where patients are in their life journey at the time. And then we had a third prototype, which was largely focused on that patient who is not well controlled, and who has continued to experience seizures despite the fact taking multiple anti-seizure medicines, failing multiple anti-seizure medicines, combining multiple anti-seizure medicines, and also having the challenges associated with the comorbidities of epilepsy, such as depression and anxiety, and how to manage that. And so these three prototypes really served as the basis of communication and discussions with some of our stakeholders, and sort of developing this final interventional design, and ultimately an outcome study that will determine what the true value of a program like this might be. Is it going to be meaningful? Is it going to make changes in the patient's lives and the caregivers' lives? And if so, is it going to be a sustainable program that we can launch at a different level? So again, this has been a pretty long journey from May of 2019 until today. And COVID, you can imagine, because I'm sure most of you who get your vaccines, you're either getting them in your clinics with your providers or you're going to the pharmacy. So you can imagine during the middle of COVID, that's all hands on deck with the pharmacy staff in COVID vaccines, and we just could not introduce anything new at this level at the community pharmacy event. And Jenny Bocci, the PI on this program, really is the one who is connected to that community pharmacy through the Washington State Pharmacy Association. So here's the vision, if you will, of this program, and we've given it a name. We've tried to sort of personalize it a little bit, and we're calling the EV. And EV begins with the patient and the pharmacist having a consultation. Imagine a day when you go into your pharmacy and you sit down and you are having this conversation with the pharmacist. I haven't yet to find a pharmacy that has a couple of nice lounge chairs and a coffee shop, but I know they're out there. I know that we do have some of those in Washington State. But the goal would be to have a quiet, confidential place that you can speak with your pharmacist and about what you're hoping for and what they might be able to do. The second aspect of this is, we'll just kind of go through this. We want to develop with the patient treatment goals, and I'm really excited to hear Dr. Holmes talk this morning about a seizure care plan, and because that is going to be an integral part of what this is all about. How do we work with Dr. Holmes and Dr. Novotny and other neurologists, epileptologists around the state to help them do what they're doing with the seizure care plan? So what are the treatment goals? Obviously, no seizures, no side effects is what I think we're all trying to shoot for here. And to be able to answer questions. Many of you, if you haven't taken advantage of it, taken advantage of something called a med sync, most pharmacies offer that. Lord, I need to get on that because I call in a pharmacist a couple of times a month to get, because I can't get my meds synced up and get them one time a month or once every 3 months. But it is a program that most pharmacies will offer, and it's something that we'll talk about. So the next aspect or stop on this journey is the development of this care plan and the integration of the pharmaceutical care plan with the medical care plan that documents and keeps everybody on the same page about the patient's goals and the effectiveness of the treatment. And along the way, we're providing educational information to the patient, to the caregivers about disease state, but also about the drugs and what they might anticipate from an adverse effect profile. And oftentimes, I'm a firm believer that knowledge is power, and being able to walk through some of the adverse effects of drugs that a patient may take is often something that can help patients manage through them, if you will. So the idea is this is not just a one-stop interaction with the community pharmacist. This is an iterative, ongoing, regular process in which the pharmacist is checking in with the patient is checking in with the pharmacist, they're communicating, but also, in that process, things can come up that, the pharmacist is alerted to things that sort of is suggesting that there's a need for a visit back to the provider, to the neurologist, and to serve as that resource, if you will, to potentially identify things earlier on than they may be identified in checkups with their primary care provider, and alert the rest of the care team to the fact that something, additional attention needs to be paid here with regard to behavioral health and mental health, as an example of this patient. So care coordination, that speaks to that, if you will. We've got the care plan for the pharmaceutical care plan, the medical care plan. How can the pharmacist help the patient coordinate that all with their primary provider, and to make sure that everybody is on the same page here, and we're all working together for the same outcome, if you will. So this begins to sort of tie it all together to close this loop in which everybody in the ideal world is talking to everybody and communicating with everybody, and the needs are understood by everybody. So that's the ultimate goal here, is that as a plan. So where are we right now? 3 years. We are really starting to launch now, and developing collaborations in the community. Dr. Gane, myself, and others have been working on an educational plan for the community pharmacists, because many of them, I know what they get in their pharmacy training, from an epilepsy perspective. And I think many community pharmacists would probably tell you, I don't know enough about all of the nuances of epilepsy and epilepsy care that I probably need to know. And so we have been developing a training program, which will have both an asynchronous part in which the pharmacist works on a module that discusses everything from the disease itself and the language around the new classification, to the comorbidities of epilepsy, the pharmacology of treating the disease, the drug-drug interactions that one might anticipate in a patient's life as they age, and making sure that they are fully aware, and building, if you will, competence in their knowledge, but also confidence in their ability to interact with the patient at this level. So that will launch actually later this month, that initial asynchronous portion. Then we have 3 modules which will be synchronous with the community pharmacy, and in which we introduce, if you will, EV. So this is the kind of material that the pharmacist will have access to, and the patient will have access to. And in that initial consultative visit with the pharmacist, the patient will walk away with a package of information, and much of this might be replicative of what they might receive in the neurologist office or the primary care office as well. But again, information is important. This is vetted information, and it'll be discussed in a manner which gets everybody on the same page. So topics include epilepsy and seizures, women with epilepsy, seizure emergencies. How do you handle seizure emergency safety? the issue of SUDEP, or sudden unexplained death in epilepsy, is a frightening topic. And to be able to understand that and have a place for patients to ask additional questions, again, and all of this is being developed in consultation, particularly with Dr. Novotny, and is helping guide us on much of what we're doing here. Everyone with epilepsy knows the importance of sleep and anxiety and trying to control stress and anxiety, but and certainly over the last 2 years, patients with epilepsy have asked the question, what about COVID and my seizures? And, Lord, hope we're coming towards an end of this for the moment. And, but these are all important questions. So I mentioned earlier an outcome study. So this initial phase of this program will be launched in 4 community pharmacies in Washington State, 2 in an urban, 2 in a more rural area. There will be an outcomes study in which we have control population and an intervention population where patients will be identified and they will enter into this intervention. We've been developing this outcome studies to ask very specific questions about quality of life. That's the primary outcome measure, as we call it in trials. But also secondary outcome measures are really, has this intervention through increasing awareness about adherence, medication adherence, led to a change in seizure control and overall health metrics as well, utilization of emergency departments and things like this. What is the outcome of this kind of thing at a population health and a community level? And then it'll also hopefully tell us a lot about how patients are utilizing their pharmacies, what can be done better, not just for epilepsy, but other disease state management. And it'll help, importantly, inform on the feasibility and the sustainability of this program. We're starting small, but at the goal, we're actually planning on and we're assuming success, right? I mean, you don't ever go into something assuming failure, but we're assuming success. And if successful, then the goal is to expand this to other pharmacies, not only in Washington State, but surrounding states and other regions where the community pharmacist has recognized provider status. And that is largely up and down the West Coast. It is moving further inland, if you will, in which more and more states are now recognizing that there is this opportunity for pharmacists to work at a different level in their license. So that's the ultimate goal. I wish I had some data to share with you today. Maybe next year we'll have some data that we can give you an update on this. But I wanted to and I really appreciate Kevin giving me the opportunity to sort of introduce this at this point and kind of tell you what we're thinking. But thank you very much for your attention. So.
Does anyone have any questions? Okay.
Thank you for the microphone. I can't talk very loud because I have a VNS. It seems to me that this is very complicated because doctors are overworked and pharmacists are overworked. And how are they going to be able to implement this type of program? Yeah. So what is this is good that you're having like a protocol. You're testing it out with different places. Is that the main reasons why you're doing that, to see if that's possible to do?
It is, and it's an excellent question, and it is a concern. I mean, that's the big issue is, can a busy pharmacy fit this in, and how would they go about doing it? You know, obviously these appointments and these touching base with your pharmacist would be by appointment. So it would be scheduled so that it is, you know, and it can be either, we envision that it could be through video chat, it could be in-person discussions. But the idea is, if the pharmacist can schedule it and around their team and their daily work, that's one aspect that'll be important. But the other aspect is the 4 pharmacies that we have identified have committed to providing the time and the resources for the patients in which they will be enrolling into their aspect of the study. And part of that study involves developing an institutional review board, or an IRB, in which, you know, patients will actually be enrolled into it. They will give permission, just like you do when you go to your provider. But ultimately, to answer your question, we can envision a day when a community pharmacist could hire a clinical pharmacist, and that is their primary role, in which it's maybe not just epilepsy, but it's disease state management. It's much like you see in clinics and hospital. They have ambulatory care clinics. My daughter's an ambulatory care pharmacist. She works with hypertension, she works with, you know, cardiovascular, and I haven't got her into epilepsy yet, but I'm working there. So that's the ultimate goal, and I think the sustainability of this is to have a dedicated clinical pharmacist within a community pharmacy setting that can spend their day interacting with patients. They can bill for that service, and it makes a difference. Ultimately makes a difference.
I think I'm pretty excited that there's a billable way for care coordination, is what I'm hearing from you. Is that right? Okay, awesome. That seems great. I have the same question as her, but I think care coordination not being billed is a huge problem. And if we can do that with a pharmacist, that would be great. I think the problems I've had, and I'm guessing other people have, is when you have a specialty pharmacy mixed with other pharmaceuticals that are your community, and you ask either of them if there's an interaction, and neither of them know the answer. So I would like to see some kind of, I guess, more communication between a specialty pharmacy and a community pharmacy, and how would you solve those type of situations?
Yep, that's an excellent question, and again, ultimately, to bring on a specialty pharmacy who has that knowledge, that access to resources. But that being said, most community pharmacies and their computers should have the capability of doing a survey of all your meds, and they get an alert, you know, as a potential drug-drug interaction. And that becomes really critical when a new drug is added to the regimen. An antibiotic, you know, that all of a sudden is inducing metabolism or inhibiting metabolism of the anti-seizure medicine can, as you well know, can take you from controlled to uncontrolled, tolerating your drug to not tolerating your drug. And so it is going to take some of that. And that's part of our education with the pharmacists, is to really alert them to these special types of drug-drug interactions that take place with the anti-seizure medicines, and the potential for losing control or losing tolerability. I will be around Michelle will be around as well. We've been working closely in developing sort of the education and actually to that point, if there are things that you think are important, we would love to hear it today because we can make sure that it's there.
Hello, my name is Jessica Veach, and I'm the Operations Manager for the Epilepsy Foundation. Our next speaker will be Dr. Mike Holmes, who will be speaking on the topic of seizure action plans for adults. Dr. Holmes is currently a professor of neurology at the University of Washington and a staff physician in the UW Regional Epilepsy Center. He received his medical degree at Ohio State University, completed residency in neurology at Letterman Army Medical Center, and fellowship in epilepsy and clinical neurophysiology at the National Institutes of Health. His clinical and research interests involve evaluating and treating people with difficult epilepsy and in exploring novel treatments for persons with refractory seizures. Please welcome Dr. Holmes.
Thank you very much for the invitation to come here. My topic today is going to be seizure action plans for adults. Much of this will be applicable to at least older children as well, especially teenagers, but my emphasis is going to be on the adult patient. So what is a seizure action plan? A seizure action plan is a set of guidelines for management of acute seizures of patients with epilepsy by caregivers, primarily caregivers and family members, the frontline people who take care on a day-to-day basis people with epilepsy. And these guidelines are going to be important. I hope to show you why they're going to be important in a few minutes here. Let's talk about some basic information. About 3.5 million people in the United States have epilepsy. About over 80% of them are over the age of 18. Most of them require continued medications. About a third of all adults with epilepsy and 45% of children with active seizures currently have a seizure action plan. The point is, a seizure action plan gives frontline caregivers some control in guiding management of seizures, which in turn may be important in reducing SUDEP, sudden unexpected death in epilepsy, and emergency room visits. As a side effect of that benefit, reducing unnecessary ER visits may reduce direct and indirect costs of healthcare utilization. Now, who are seizure action plans most useful for? Patients, in general, patients who have refractory seizures, people who need help in identifying seizures. People with epilepsy often have significant memory impairment. And with memory impairment, they don't remember that they've had a seizure, and they need help. And especially that's true in people who have frequent nocturnal convulsive seizures. A patient who does have frequent nocturnal convulsive seizures is at a higher risk, we believe, of SUDEP. Also, people who are in the special categories, older adults with epilepsy, people with developmental disabilities, people who are at risk of cluster seizures, and I'll talk about cluster seizures in a few minutes, and people who live far from medical care or live in assisted living facilities. So I would say that all people who have active seizures require a seizure action plan. But these are some of the categories of patients for whom I think it's going to be most useful for. Now, caregivers, the other side of the coin. Caregiving is can be a very stressful situation. The unpredictable nature of epilepsy renders the caregiver at risk of having increasing stress and anxiety. The caregivers may need help in determining what is not an emergency, and they may have help. They may require help regarding the patient's seizure profile and treatment. So it benefits the patient, and it also benefits the caregiver having a seizure action plan. Okay, what are the qualities of, what I think are the qualities of an effective SAP? I think you should use very simple language, and I think you need to present it in a way which is understandable to people who have the least understanding of epilepsy, or least knowledge of epilepsy anyway. Who knows, who may be required to use a seizure action plan? Maybe grandparents, maybe babysitters, people who don't necessarily have a great deal of knowledge about epilepsy. So it should be presented in a format which is easily understood. I'll show you an example of a seizure action plan later, but using graphics and color coding to illustrate points may be important. And the seizure action plan should be tailored to the specific needs of individual patients. It should be revisable and dated to the most frequent current status. Okay, who's going to use an SAP? Obviously, caregivers, the frontline people, caregivers and family members, and maybe one and the same. Caregivers are often family members. School personnel. I have young adults in college and with epilepsy, and it's useful to have an SAP available for school personnel. If they're lucky enough to have a job, co-workers of the patient should be able to access an SAP. And of course, in medical facilities, I think that's less important than the first three categories that I mentioned. But sometimes in urgent care facilities and ERs, an SAP can be quite helpful. Now, the SAP needs to be customized to the individual patient. It should have contact information, how to recognize the patient's typical seizure pattern, how to administer seizure first aid, and what do you do in other situations? And I'll talk about those other situations in a few minutes, but you need to recognize when you should use rescue medications or when you need to call for help and what to do. So basically, a seizure action plan should contain these three main factors: seizure first aid, when to use rescue medications, and when to call for help. Now, I like this seizure action plan developed by a group called Action Epilepsy, a UK-based organization. A single page, the top of the page contains basic information about the patient. In graphical form, they illustrate in the next section, illustrate the type of seizure that the person has, and then how do you take care of the person who's having a seizure? The green light row illustrates seizure first aid, putting the patient on their side, cushioning the head, and so forth. And I'll go into seizure first aid in a few minutes. Now, if you need to use rescue medications, the yellow light row shows modes of administration, either rectal or nasal or oral administration, and the type of medications that are going to be administered by the caregiver, the first-line provider, and when to call for help, the red line. The red light row. The seizure is prolonged, if the seizure is atypical, if the patient has sustained an injury as a result of the seizure, the circumstances in which you should call for help. So it's a single page, and it gives you in a graphical form what to do, basically. And it should be, like I say, the seizure action plan should be accessible to people who have not necessarily a great deal of knowledge about epilepsy. Okay, so what do you do for a tonic-clonic convulsive seizure? First of all, keep your head and remain calm. And your main goal is to protect the patient. Patient has to be moved out of dangerous situations. You should stay with the patient, cushion the head, turn the patient on the side so they don't aspirate on their saliva. Don't try to restrain the patient. In the middle of a convulsive seizure, it's dangerous to try to restrain the patient because you might injure them. They may cause fractures or some other serious injury if you try to restrain a person having convulsive seizure. Don't put anything in the mouth. Note the time. You have to keep all these things in your head while you're going through this situation. But if you stay calm, you can note the time. You have to get a rough idea as to how long the seizure lasts. And I also think you should encourage onlookers to move along. People have many types of reactions. If they're just casually bystanders and they're walking along and they see somebody having a seizure, onlookers can have a variety of reactions. And their emotional reactions can vary from hysteria to equanimity, but you can't deal with the onlookers' hysteria if you're taking care of the person with a seizure. So encourage onlookers to move on. And then you should stay with the patient until fully recovered. I'm hoping to show a video clip here that outlines some of these points here.
Assess the situation. Are they in danger of injuring themselves? Remove any nearby objects that could cause injury. Cushion their head to protect them from head injury. Check the time. If the seizure lasts longer than 5 minutes, you should call an ambulance. Look for a medical bracelet or ID card. It may give you information about the person's seizures and what to do. Once the seizure is over, put them on their side in the recovery position. Stay with them and reassure them as they come round. Never restrain the person. Put something in their mouth or try to give them food or drink.
Okay, now what about focal non-convulsive seizures? Again, remain calm. As a caregiver, you have to be calm, keep your head, and you need to protect the patient more than anything else. Move the patient out of dangerous situations. For example, away from a hot stove, or away from water, or situations that are potentially dangerous for patients who do not have full control over their cognition. Again, don't put anything in the mouth. Don't restrain the patient, but kind of guide them gently along out of the dangerous situation if they're in a dangerous situation. Time the seizure and stay with the person until they're fully recovered. And again, I emphasize, try to get the onlookers to move along. And I'll show you a video clip that illustrates these points as well.
First aid for a complex partial seizure is aimed at protection. The person should not be restrained, but rather gently guided away from dangerous areas or activities. You should talk quietly and calmly while encouraging the person to sit down and rest until fully alert. After the seizure has ended, the person should be told of the seizure and reassured that everything's all right.
Okay, now the next step. When do you use a rescue medication? There are three basic situations in which you should consider using a rescue medication. One is to manage a seizure cluster, and I'll talk about that in a few minutes. If the seizure lasts more than 3 minutes, or if the person has a seizure that is atypical or is more severe than they typically have. Again, you have to understand what their seizure is like to make that determination, but these are the basic points. And I would say the most important point is how to manage a seizure cluster. What is a seizure cluster? Now, you'll find a huge array of definitions of what a seizure cluster is. For adults, I think the consensus is that if you have 2 or more seizures within a 24-hour period of time, that constitutes a seizure cluster. Okay, now the patients at risk of having a seizure cluster are those people who have very difficult or frequent epilepsy. In adults, I would say that the patients who have so-called extratemporal focal epilepsy are at greater risk. If they have a longer duration of epilepsy, if they're poorly controlled, these people are at risk of having seizure clusters. And I have to say, there are patients who only have seizures in seizure clusters. So again, this gets back to knowing what the patient's pattern is. I talked about using a rescue medication if the person has 2 or more seizures. But if you know the person's pattern, if they have only seizure clusters as part of their syndrome, you should treat them for a seizure. That's part of the individualized nature of your seizure action plan. And there are some patients, at least a quarter of patients, this study came out of the Middle East, a quarter of adults with new onset seizures start off with a cluster seizure. So it's a huge problem for people who have difficult epilepsy. Okay, I'm not going to get too much into the research area of what causes a seizure cluster, but I'll just mention this one study. In an animal study of status epilepticus, they looked at the pattern of seizure clustering after the period of status. And what they found was that abnormal brain proteins are expressed during the clustering period. You don't have to know anything about the rest of this slide, really, but in the area underneath the area of seizure cluster, it represents patterns of abnormal brain protein expression in both the hippocampus and the cerebral cortex. So there's something about the epileptic brain that predisposes people to abnormal homeostasis, abnormal susceptibility to neuronal excitability. And these abnormal protein expressions may be a manifestation of that. Why treat clusters? Well, they increase the risk of injury greatly. So you need to treat them for that reason alone. But worse can happen. They can progress to status epilepticus, which is a continuous form of seizure activity or a series of seizures in which the person does not regain awareness in between seizures. And seizure clusters predispose people to SUDEP, death. So the frontline provider has a role to play in managing seizure clusters. Mortality is clearly increased in people who have seizure clusters. This epidemiological study came out of Europe. The line at the top, which is dashed, indicates people with epilepsy who do not have clusters, and the bottom line represents people who do have cluster. The x-axis represents time after the onset of seizure, and the y-axis represents the proportion of survivors after the onset of the seizure. So you can see there's a clear divergence. So people with clusters die more frequently, quite simply. Now, impact is there's more to it in terms of effect on the patient's lives. It interferes with their ability to work and school, can't be involved with normal daily activities, increases the incidence of emergency room visits and hospital admissions, as well as healthcare costs. It greatly disrupts family life, increases stress for caregiver and family members both. So it really has a significant impact on a person's life if they have to deal with a seizure cluster. And it doesn't have to be a convulsive seizure cluster either. It can be non-convulsive focal seizures as well. So people are significantly impaired with having a cluster of complex partial seizures, as well as a cluster of convulsive seizures. Now, the impact of a seizure cluster extends to caregiver as well. The caregivers are prone, in some cases even more prone to emotional stress as the patients themselves. They can't drive, they can't work. It has an impact on their family life, ability to participate in extracurricular activities and so forth. So if you can prevent or at least treat seizure clusters, have the ability to control seizure clusters, you can have a significant impact on both patient and caregiver. So, rescue medications. It's probably true that only about 1 in 5 patients who could benefit from rescue medications actually receive them. And the rescue medications can be given in 3 forms, 3 modalities of treatment: orally, rectally, or intranasally. And I'll go through some of these. There's 2 forms of oral rescue medications: oral lorazepam, which is my preferred oral rescue medication, usually given 1 to 2 milligram dosage. But the big drawback of an oral medication, you have to be certain that the person is awake enough to take it. You cannot risk aspiration. So this is the big drawback for oral medications, in my opinion. The person has to be alert and awake enough after a seizure in order to be able to take the medication. It can be given, it can be swallowed, it can be placed under the tongue, sublingually, or placed between the tongue and the cheek, which is called buccal administration. The absorption may be faster with sublingual or buccal administrations, and the effect is fairly rapid within 15 minutes or so. And you should arrange with the medical provider in advance if and when a repeat dosage should be given. And I think it's fair to say you should not give people oral medication if they have difficulty in swallowing for whatever reason. Not just impaired consciousness, but if they have a baseline difficulty swallowing. Some people, most people can handle lorazepam okay, but some do not. Some can't handle it. Some people have paradoxical reactions to lorazepam, whereas lorazepam may in some cases cause sedation or drowsiness. In other people, it can cause a paradoxical reaction emotionally, and it's not a good drug for them. Those are relatively uncommon, but it does occur. Oral diazepam can also be given, and I have 1 or 2 people who use oral diazepam as preferred to oral lorazepam. Can be swallowed, given sublingually or buccally, and again, you should not give it to the person, a medication orally, if they have difficulty in swallowing or they're not cognitively with it enough to swallow the medication. And you should also arrange in advance with the medical provider for directions regarding repeat dosage. Now, Diastat is a rectal administration of diazepam. It's usually given in prepackaged formulations, a gel formulation, 15 to 20 milligram. It can take effect within the minutes. Peak effect is achieved in about an hour and a half, and the effects may persist for 48 hours. It is a difficult drug to use in a public setting, and you should be cautious in using this medication in people who have difficulty breathing or in the elderly patient. Whatever else you can say about it, it does work for the most part, especially effective in people who have frequent convulsive seizures. And I do have people who actually prefer, caregivers and patients prefer Diastat to either oral or intranasal forms of medication because it is effective. Midazolam intranasally can be administered as well. It's a very attractive alternative rescue medication. The person can absorb the medication rapidly, more rapid, in fact, than oral or rectal administration of medications. It's typically given for an adult patient in 5 milligrams in nasal spray. May repeat it in 10 minutes if prescribed. Again, you have to use it in caution in people who have difficulty breathing or in elderly people. Sleepiness and side effects are common side effects and can be used to treat a cluster every 3 days or so. I like midazolam a lot, but there are some people who do have abnormal or unacceptable side effects to this medication, prefer not to use it. but I would say most people can tolerate it pretty well. And then you have intranasal diazepam. Also, like midazolam, it's an attractive alternative rescue medication. The initial dosage has to be adjusted for age and weight. Typical dose ranges between 5 and 20 milligrams, may be repeated 4 hours after the initial dose, if prescribed. And again, like midazolam, it has to be used cautiously in people who have difficulty breathing or in the elderly subject. And you can use it to treat a cluster about every 5 days or so. So we have an array of rescue medications that can be used. And the precise type of rescue medication should be worked out with the medical provider. But I would say that most caregivers prefer the intranasal forms of medication. And for obvious reasons, I think. I mean, it's faster. Patients tolerate them pretty well. And it's easily administered. Now, how effective is rescue medication? Well, the frontline caregivers do have a significant role to play. Fewer injuries, a whopping 2.5% versus 90% favorability with fewer injuries. And they have fewer ER visits. So it does work. So the caregiver, the frontline caregiver, has an important role to play in using rescue medications in treating particularly cluster seizures or seizures that are prolonged or seizures that are unusual. But I think that this is a staggering statement, if you will, how effective rescue medications can be used in the right way. When do you call for help? I think you should call for help for the very first seizure, because you never know what you're dealing with the first seizure. Could you be dealing with a brain tumor? Could you be dealing with intracranial hemorrhage? So you just don't know for sure. So I think the first ever seizure should be indication to call for help. If the seizure lasts for more than 5 minutes, if an injury occurs, if the seizure is not typical of what the patient usually experiences, or if the patient becomes cyanotic, which is they become blue. And of course, if rescue therapy does not work, you should always call for help. In summary, these are the components of an effective seizure action plan. How to perform seizure first aid, which is really quite simple to do for most people. And people who do not have any special experience in epilepsy can do it. Most adults can do it. And when to use rescue medications. And caregivers get to be pretty good at using rescue medications. And finally, the guidelines should include when to call for help. Thank you very much.
So what is a cluster seizure in your opinion? Is it only tonic-clonic?
No, a cluster seizure can be a focal seizure also. In people who have focal seizures, if they continue to have focal seizures in a short period of time, that can progress to more severe seizure types, including convulsive seizures, including status epilepticus. So a seizure cluster can include focal non-convulsive seizures as well.
Okay, I know that names of seizures keep on changing. So a focal seizure, is that similar to absence seizure?
I'm sorry?
Is a focal seizure the same as an absence seizure?
Absence seizure?
Absence.
No, they're two different. They're two different seizure types. An absence seizure, the classic absence is a brief 5 to 10 second seizure that occurs typically in children. We don't see it we do see it in adults, but not as often as in children. It's mainly it's a form of what we call generalized epilepsy.
Okay.
An absence seizure is not the same thing, and whether or not you treat status or frequent absence seizures I didn't really address that point here because it usually doesn't come up in adults very often. But it's different than a focal seizure. Focal non-convulsive seizure in adult is a more serious matter, in my opinion.
Okay, so that can't be used for eps and seizures then,
Well,
if there's multiple all day.
you can use a rescue medication in treating absence, but I don't. Well, absence seizures are more subtle, tend to be more subtle, and they're not as deleterious to the patient's well-being as a focal non-convulsive seizure of temporal lobe origin or extratemporal epilepsy.
Okay. Thank you. Oh.
I just have a question regarding nocturnal seizures. Could you elaborate on that?
Nocturnal seizures, there are many people who only have seizures or mainly have seizures at nighttime. And if they have, the problem with nocturnal seizures, nocturnal convulsions, is that we think it's a risk factor for SUDEP, sudden unexpected death. So if you have a cluster of convulsive seizures at nighttime, that's a clear indication for rescue medication. Any other questions?
Yeah, I have one. Or actually, I have two questions. So the first is, if I feel a seizure, I've never used a rescue medication or whatever. So if I feel a seizure coming on, is that an appropriate time to use it, or is it something once you're having a seizure to use?
Well, that's a good question. There's some neurologists who would treat a seizure like that. Others would not. Typically, a rescue medication, if your seizures occur infrequently and you have what we call focal aware seizures, whether or not you treat that is up to you and your provider. It all depends on how the seizure affects your life. But sometimes focal aware seizures can occur in clusters. They can progress to complex partial or focal unaware seizures, and that's why the seizure action plan has to be individualized to understand the nature of the patient's problem, how often the seizures occur, how do the seizures affect their life. Those are all issues that have to be taken into account in developing the seizure action plan.
Okay, cool. Sweet. I have one more question. Okay,
Yeah.
So say there's a scenario where you have a tonic-clonic, it lasts for more than 5 minutes, so someone calls for help, but you know that it's not a cluster. Is it always that when you call an ambulance, you should go to the hospital? Or say there's a scenario where there's a point of contact, that point of contact is on their way, they get there. Can they say, all right, I'm good, I don't need to go to the ER? Or is that a situation where you always go to the ER just to be safe?
The answer is it depends.
Okay.
There are situations where the caregiver has to go through all three modalities: seizure first aid, rescue medication, and still have to call for help. That does happen. I see that happen frequently. If you really know the patient and you know the nature of their seizures, and it tends to be an isolated seizure, even though it lasts for 5 minutes, it's going to be a matter of judgment as to whether or not you call for help. But if you're the caregiver and you're uncertain, I would say call for help. But there are people who, as you say, they have the rescue medication, they still call for help, the ambulance arrives, and the person's awake, and that's fine. You know, that obviates the need for an ER visit or hospitalization.
Awesome. Thank you.
I actually have two questions. I frequently give seizure first aid trainings, and one question I get is, does it matter which side we turn them on?
No,
Okay. And then the other one is turn them on their side during the seizure or wait till the seizure has finished?
It can be difficult to turn the patient on their side when they're actively having a seizure. But you should at least try to do it as soon as the convulsive phase of the seizure is over.
Okay, thank you. Any other questions? Oh, yes, in there.
Thank you. Oh,
Actually, let me jump in with the stream. We've got a couple questions on the stream. I'll ask one, and then Mary, you can go. One of them is, can rescue medication be used in the midst of a tonic-clonic seizure? Is there any protocol that can be used to shorten the seizure?
Yes, they can be used. Diastat will be difficult to use, but I know patients, caregivers have given Diastat during an active convulsive seizure, and it can work fairly effectively. But then that's where the advantage of the intranasal medications come in, because you can use it during their active seizure phase. Oral medications are not a good idea during an active convulsive seizure.
Thanks. Mine is I'm an organizational person. So is there a standardized structure of the seizure action plan? Because I know what I need to give to the school for my daughter, but that one you showed up there does not look like that one. And I would like it in English for my family members that might take care of my daughter.
Yeah, I mean, you go to the literature, there's dozens of seizure action plans out there. Some of them are multi-page documents. I think the simplest, the better.
Yeah, me too.
That one that I showed you is from a group called Epilepsy Action.
Hey, Mark,
I'm guessing.
can you move closer to the
Oh.
mic? So
Oh, yeah, based out of the UK. The one that I showed was a single-page document that I kind of like. I think it's a very, very nice document.
Yeah, I'm just always trying to make it easy for the caregiver so we can have a standardized one that everybody uses. would be
It should be
amazing.
accessible to anyone who deals with on a day-to-day basis with the patient.
This one back here.
I was curious with the 2.5 versus 90% injury rate when you administer the rescue medication. I'm just curious how you think that happens if you're waiting 3 minutes to administer that and then it takes 15 minutes to start working.
Well,
And someone's convulsing in the first 3 or 5 minutes. How that works.
The study was done in people, comparing people who had seizure clusters. The group was not treated with any rescue medications, opposed to the other group that was treated with a rescue medication. So the group that had the higher rate of injury was the group that had continual convulsive seizure. Each time you have a convulsive seizure, that puts you at risk of trauma. From dental injuries to orofacial injuries, to head injury, to lacerations, dislocated shoulders. So it's a cumulative effect. So you may have to have the first seizure. You may have to have the first seizure, and then you get a rescue medication. But then that cuts your risk of injury greatly. That's what the data shows.
I was wondering how that 5-minute mark came about, especially after you said with the injuries, why wouldn't you give it sooner to prevent injuries? And how did the medical community come up with the 5-minute standard?
Well, there's no consensus actually. It's some people say 5 minutes, some people say 10 minutes actually. I prefer 5 minutes. I think that if you have a seizure that lasts more than 5 minutes, that can be very dangerous, especially with a convulsive seizure. So there's no set standard. The literature says 5 minutes, 10 minutes, and there's no basic basic consensus of opinion as to how long you should wait, but I tell people call after 5 minutes.
Dr. Holmes, if just several related questions. What is the failure rate of Valtoco and Nasalem? Let's say that you give it after 5 minutes or whatever. Do you automatically have them call an ambulance? Or if you know it's going to work because you've used it in the past, is it okay to wait until you get the second dose of the rescue medicine?
I think so, yes.
Okay,
I
good.
think it is, yes.
So you said you can repeat Nasalem in 10 minutes. What was the Valtoco? You said it was hours, wasn't it?
4 hours.
4 hours, right.
Yes.
So when would you repeat a Valtoco dose then? If you gave one and they're still seizing? Or you would not even repeat it at all, right?
I think that I would, if you've talked it over with the provider and the provider says, yeah, go ahead and treat it, I would treat it. Otherwise, I think you need to call for help.
Right.
If it doesn't work after the initial dose of medication.
For Valtoco?
Yes.
What if the first dose of Nasalem doesn't work? Just give the
Same.
second dose?
Same thing, yeah.
So call if you fail the first rescue?
Yes.
Okay, thanks.
Yeah.
Another question from the stream here is, what percentage of people have breathing difficulties after midazolam has been administered?
It's not a high percentage, but it does exist in some cases. If you have adult patients, some people have asthma, some people have chronic obstructive pulmonary disease. Some adults have respiratory diseases that put them, they're kind of fragile in terms of their respiratory status. So you have to be careful sometimes in administering medications like that. For most younger people, it's not an issue. But for people who have COPD and asthma and other respiratory conditions, that can be a big issue.
And then another one was, where do you find a seizure action plan form like the example you showed? And they've talked about that. There are some on epilepsy.com, but go ahead, Mark.
Yes, you can find it. You can find it on the internet. There's many different seizure action plans on the internet. I don't like them so much because they're too. They want you to fill in too much details. I think something very simple and easy to follow, like the one that I showed you, is preferable. But you look up seizure action plan on the internet, and under images you can access the one that I showed you.
All right, any other questions?
I have one, my own personal one. About 20 or so years ago, I took the medication Ambien, which is sleep assistance medication, and about 12 or so hours the next day in the afternoon, I think it was, I started having cluster seizures, like every 2 minutes. One would stop and then another one would start. The question is, have you ever seen any other patients have a reaction to sleep assistant medicine, or am I the abnormality?
I have not.
Oh, Jessica says she has.
I haven't seen it very commonly, I must say. Well, I have not seen it very commonly, Kevin.
Thank you, Dr. Holmes. We're going to take, let's say, a 15-minute break, and we'll start back at 10:45.
Hi, I'm Lane. I volunteer for the Epilepsy Foundation, and I have epilepsy myself, and I've had it for a long time. Our next speaker will be Michelle Kim, who will speak on the topic of epilepsy and behavior health. Dr. Kim is a board-certified clinical neuropsychologist and an associate professor through the UW Medicine Department of Neurology. She obtained her Ph.D. in clinical psychology from the Fuller School of Psychology and completed a postdoctoral fellowship in clinical neuropsychology through Cambridge Health Alliance and Harvard Medical School. Her primary care service is providing pre- and post-operative neuropsychological evaluations for patients with drug-resistant epilepsy through the UW Regional Epilepsy Center. She also serves patients referred through the UW Memory and Brain Wellness Center and outpatient neurology clinic. Her clinic research focuses on cognitive outcomes through open resections versus selective laser ablations in the treatment of drug-resistant epilepsy. So please welcome Dr. Kim.
Great. Thank you for that introduction, Lane. I'm going to apologize in advance. I'm kind of getting over a cold, so I may be coughing a little bit. So like Lane stated, I'll be speaking about epilepsy and behavioral health. All right, so a really quick overview. I'll be talking about the most common mental health comorbidities in epilepsy and the etiologies that may contribute to those mental health comorbidities. And then I'll kind of end with talking about a couple other psychological comorbidities that maybe aren't quite as common. And a really quick note, so this is a pretty basic talk. If you are here and you've had epilepsy for a long time, or you're a family member who has a family member who has epilepsy, this information may be really familiar to you, but this talk is really just to raise awareness of kind of the things that can impact the psychological disorders that can kind of impact our patients with epilepsy. So probably no surprise to you that one of the first things I want to discuss is depression. It is the most common mood disorder worldwide. It is suggested that 1 in 6 individuals in the US will actually experience depression at some point in their lifetime. And there has been research done looking at patients with epilepsy, and they did a survey asking how many of these individuals actually experience depression, and they found that patients with epilepsy actually report having depression twice as much as those who do not have epilepsy in the prior year. And this was actually higher if the epilepsy was active. So the epilepsy was not being successfully treated by medication or by other interventions, such as surgery. And so so individuals who had active epilepsy were actually 3 times higher reporting depressive symptoms in the prior year. Meta-analyses kind of looking at reports of depression in patients with epilepsy found that 11 to 62% of individuals endorsed epilepsy. And you're probably thinking that is a huge range. And it is, and that is likely due to the fact that people kind of classify depression differently. And the research studies that they examined may have also determined whether or not someone had epilepsy differently as well. So it could have been via self-report or someone who actually had an EEG study that showed electrographic changes that were consistent with epilepsy. So that's probably why that range is really high, but it does impact a significant portion of our patients. In addition, unfortunately, those with epilepsy are about 4 times more likely to be hospitalized because of their depression, meaning that their depression can get really severe. You're usually not hospitalized for your depression until, it does become severe and problematic. And the risk for suicide is 10 times higher in those with epilepsy. And there's actually a research study that suggests it's up to 32 times higher. So you see why it's really important to kind of address depression in our epilepsy population. So what exactly is depression? I should start off by saying mood disorders are kind of like the overarching term, and then there are different types of depressive disorders that fall under them. And when we think of depression in kind of layman's terms, when someone says, I have depression, we're generally referring to a major depressive disorder. And for psychologists and for psychiatrists, we generally turn to what is called the DSM-5. That's the Diagnostic Statistical Manual for Mental Disorders, and they give us clear criteria on how to diagnose depression. And so to diagnose a major depressive disorder, an individual must have either depressed mood or less interest or pleasure in things that they used to enjoy. So one of those 2 items. And then they have to have a total of 5 of these 9 items. So again, one of those 2, as well as either significant weight loss or weight gain when they're really not trying to lose weight or gain weight. In children, it could be a kind of a failure to make that weight gain that's expected for their age. These patients may experience insomnia or excessive sleeping. They may experience kind of psychomotor agitation, so being restless, kind of moving around a lot, or psychomotor slowing. They may endorse fatigue, loss of energy, feeling worthless, or having this inappropriate sense of guilt that is beyond, what makes sense for what they're going through. Kind of a reduction in cognitive efficiency, kind of having difficulty thinking, concentrating, being really indecisive, and then also having these recurrent thoughts of death, recurrent suicidal ideation, or having a suicide attempt. And these symptoms must be present nearly all day long, every day for at least a span of 2 weeks. And so again, at least one of the first 2, and then 5 total of those 9 symptoms. In addition to that, the symptoms need to cause a significant level of distress or impairment in their social functioning, occupational functioning, or other area functioning, such as if it's a child in school. The episode of depression cannot be a direct effect of a substance, so some sort of drug or another medical condition. So it's really well known that something like a hypothyroidism, if not well treated, can actually mimic a depression. So again, it can't be due to something like that. Also, it cannot be better explained by a psychotic disorder. And the individual cannot have a history of a manic or a hypomanic episode, so where they have excessive energy beyond what would be considered normal. So those are the criteria. In addition, what we do is we kind of define whether or not this is a single episode, it's the first time this has ever happened, or if it's a recurrent episode where the individual continues to experience these episodes on and off throughout their life, whether in terms of severity it's mild, moderate, or severe. So we make those qualifiers. And if it is severe, we generally state whether or not there are associated psychotic symptoms, because once a depression becomes severe, you can experience psychotic symptoms. And then also whether it's active, so current, ongoing, and partial remission, where some of the symptoms have improved, or if it's in full remission. So the depression really is no longer there. Another depressive disorder under that mood disorder category is persistent depressive disorder. This was previously called dysthymia, and this is kind of a low mood that persists for a very long time. So it may not be as severe as a major depressive disorder could be, but it's kind of this low mood. And this low mood needs to be present for at least 2 years. In children and adolescents, like it suggests, it can be irritability instead of this depressed mood, and the span for that can be about 1 year. And so for the PDD diagnosis, you do have to have the depressed mood or irritability, and then you have to have 2 additional symptoms, so either poor appetite, the sleep issues, energy issues, low self-esteem, the cognitive difficulties, and then or feelings of hopelessness. And again, kind of like with major depressive disorder, these symptoms need to be present nearly all day, every day for a span of 2 years. However, that is a very long period of time. And so you can still be diagnosed with a pervasive depressive disorder if there is this period of time that's less than 2 months long where you do not experience these symptoms. But like major depressive disorder, you cannot have had a manic episode or a hypomanic episode. Again, it can't be due to a psychotic disorder. It cannot be due to a substance or another medical condition, and this has to significantly impact the individual's life in some way. So while those two diagnoses are probably the things that impact our patients the most with epilepsy, There has been some research to suggest that patients with epilepsy actually don't frequently meet those criteria because they're very specific, right? And you have to experience these symptoms every day, all day long for 2 weeks or for 2 years. And so with our epilepsy patients, you may see periods of time where, a medication's really working for them. And so they have an improvement of mood. And so they don't report depressive symptoms. And that can go on for a couple days, several weeks, months, right? And so they may not meet criteria for an MDD or a PDD. And so there's been some researchers that suggest that maybe a better term for this is a dysthymic disorder associated with epilepsy, because our epilepsy patients can have this kind of chronic dysthymic pattern of depression, but it doesn't quite meet DSM criteria. And I put neurotic traits in quotes here because this is from an older paper. This is probably not a term that we would use now. But it also suggests that in addition to this kind of dysthymic history that some of our epilepsy patients may have, fewer of the kind of anxiety-based depressive symptoms that we may see in like a major depressive disorder or a pervasive depressive disorder. Another common mental health issue that our epilepsy patients have is anxiety. Oftentimes people think that anxiety is actually under the mood disorder umbrella. It is not. It has its own umbrella. They're anxiety disorders. And anxiety is often comorbid with depression. And so that's completely separate of epilepsy. So someone who has depression oftentimes will have anxiety. Someone who has epilepsy will oftentimes have anxiety as well. And then, as you can imagine, someone who has epilepsy oftentimes has both depression and anxiety. The anxiety is actually much higher for those who have drug-resistant epilepsy, so continuing to have seizures despite being put on medication. And it's also higher for those who have temporal lobe epilepsy. And you might see why that could possibly be the case a little bit later. It's also reported actually that anxiety may be more common than depression than the general population, in the general population. The study that I mentioned earlier that looked at depression in epilepsy patients also looked at anxiety. And they found, just like with depression, that individuals with epilepsy report anxiety twice as much as those who do not have epilepsy. And when they looked at active epilepsy, that number didn't change. And then in terms of percentages of patients with epilepsy that report anxiety, this range is a little bit smaller, but it's about 11 to 29% of patients actually endorse experiencing anxiety. So what exactly is an anxiety disorder? So I'm not going to go into all of the different criteria that are necessary to meet for the different anxiety disorders like I did with MDD and PDD. But the DSM-5 does state that with all of the different anxiety disorders that are out there, that there are these 3 core features that kind of are present in most anxiety disorders. The first one is this excessive fear and anxiety that results in some sort of behavioral change. The second is that the anxiety is beyond what's considered appropriate developmentally. So if you think about, let's say, a young child who's going to preschool or kindergarten, and they're fearful of leaving and separating from their parents, that kind of separation anxiety is developmentally normal, right? If we were to see that later on down the line, that would be less developmentally appropriate, and an anxiety disorder might be something that we consider. And then last, the anxiety must be persistent, typically lasting for at least 6 months or longer. So these are some of the anxiety disorders that I do see clinically in my patients. Like we talked about, separation anxiety disorder. Oftentimes my patients will say, I I'm so used to being around a caregiver or a family member because I may experience a seizure and, I like to have someone around me. And when they have to separate from that caregiver or family member, that can produce anxiety. They may have specific phobias, kind of speaking in public if, they feel like their epilepsy has impacted their language functioning. I've also had patients who are afraid of kind of leaving their home. They've stated that they've had seizures and been taken advantage of, had things stolen from them, or have been beaten because bystanders thought that they were making fun of them. So they may have specific phobias. They may have social anxiety because they're worried about how their speech comes out when they're with other people. They can experience panic attacks or have a panic disorder. And you can see in that picture kind of all of the different emotions, feelings, sensations that someone might experience that is going through a panic attack. They may have fear of kind of being in certain spaces or situations. They may just have overall anxiety about kind of everything. That's what we would call a generalized anxiety disorder, where they're just anxious kind of all the time. And then the last one I put on there is anxiety disorder, NOS, which is what I often diagnose with my patients with, is this kind of just low-grade anxiety that they feel. It's not about everything, but there's just this general low-grade sense of anxiety. So what are the potential causes or etiologies of kind of these the depressed mood and the anxiety? And one of the biggest things I hear from my patients is a reduced quality of life due to kind of the severity of their epilepsy. So, for patients with epilepsy, you cannot drive within 6 months in the state of Washington of having a seizure. And that is really hard on our teens who have friends who are starting to drive and who are getting their licenses. In addition, if you're working or if you have family and you have different responsibilities you need to get to, it's really hard if your ability to drive has been taken away and public transportation is not as great where you live. There are also a lot of other things that our patients have to worry about. So making sure that if they're cooking with someone around. I've had patients who have burned themselves, cut themselves, from cooking through the oven or the stove or a knife. Even little things like making sure like they're not carrying around liquids that are too hot if they have frequent seizures. The idea of taking a shower versus taking a bath, because you could potentially have a seizure while taking a bath and drown. How your bed is positioned. It's all these little things that our patients have to think of, and you can imagine that would cause a lot of anxiety, and the quality of life changes would impact mood as well. We often have to ask our patients, what are your hobbies, and they may say, I enjoy bicycling, I enjoy snowboarding, going on hikes in the mountains, hunting. And these are all conversations that I need to have with my patients saying, we really need to talk about safety when it comes to those things, because we have had patients injure themselves while doing these activities. So again, quality of life is a huge factor. Another etiology, of course, is medication side effects. Our medications are not benign, right? This is not an exhaustive list of the medications that we use, but these are some of the more common ones, I would say. But they can impact, cause low mood. They can cause irritability and aggression. I'm sure a lot of you have heard of like the term Keppra rage, right? So levetiracetam, the brand name is Keppra, can be associated with a lot of irritability and aggression. I'll get patients or family members coming in saying, this is so uncharacteristic of me, but I don't know what's going on with me. All of a sudden I'm lashing out at family members. I was in the car and someone cut off my partner, and now I'm like yelling out the window at people. Like, what is going on? I don't know what's going on. And a lot of times they'll say, what medication are you on? And sure enough, they're on Keppra, and we encourage them to talk to their treating provider about that. Unfortunately, some of our patients can experience suicidal ideation or homicidal ideation. They can impact anxiety, nervousness, and then also psychotic behaviors. The thing to note is that just because someone is on these medications, it doesn't mean that they're going to experience these symptoms, but these are things that can occur, and some of them are at smaller rates, but they're just things that you should be aware of. In addition, there can be a temporal relationship to seizures. So some of the symptoms that we see aren't really they're not a major depressive disorder. They're not an anxiety disorder. It's specifically related to when the seizures occur. So with depression, we can see people, again, this is not everyone experiences this, but there is a certain population that can experience pre-ictal depressive symptoms. So several hours to several days prior to a seizure, they can start feeling a little depressed. And then it's most severe typically within the 24 hours prior to a seizure. And then in the ictal stages, during an aura, about 15% of patients will report some sort of mood change. And then post-ictally, they may report depression kind of the same day of the event to 5 days post seizure. And most often it's reported that the depressive symptoms last for about 24 hours. And it should be noted that these symptoms are brief and kind of time limited. It's not like a major depressive disorder that's kind of this long chronic issue. And these are the symptoms that a patient may endorse, kind of in order of the most often reported to the least often reported. Anxiety symptoms kind of follow the same pattern. So pre-ictally, they can occur several hours to several days before a seizure and then become more severe leading up to the seizure. And then in the ictal stage, for those who have complex partial seizures and have an aura that precede the seizure, about 10 to 15% of those patients will state that they have this fear response during their auras. And then post-ictally, they may endorse anxiety symptoms from the same day to about 7 days, so a little bit longer. And those who have drug-resistant epilepsy may report a longer period of anxiety post-seizure. And then again, these are the symptoms that are often reported, with nervousness being the most common symptom reported. And then additional etiology. So, in terms of epilepsy, the most common form of epilepsy is temporal lobe epilepsy, which impacts those kind of mesial temporal structures of the hippocampus and the amygdala. And interestingly, there's been a lot of research to show that with depression, there is the hippocampus can actually look a little bit smaller on neuroimaging than general controls. And the research also shows that the more severe the depression is, the more atrophy or the smaller volume you can see of the hippocampus. So, it's interesting that they're kind of impacting the same areas. There's also research to suggest that individuals with epilepsy may actually develop depression prior to the onset of their first seizure. And so, that kind of suggests that there's this possibility that the structural changes that may happen with depression could actually make someone more susceptible to developing seizures. But it goes the other way around as well, right? And so the structural changes that possibly occur with epilepsy may also make someone more prone to developing depression as well. It's kind of the similar thing with anxiety. So the amygdala, again, in those mesial temporal structures, the amygdala is kind of what controls your emotional fear response to certain situations. And the hippocampus is what's really implicated in kind of building memories, right? And so it unfortunately creates this not so good feedback loop. So you have this fear response, and then you have this memory of that fear response, and kind of helps you kind of replay that fear response in your head and in certain situations. So it creates this feedback loop. And again, in temporal epilepsy, these similar regions are implicated oftentimes. So what do we do for our patients? Again, we need to determine, like, is this really time related, associated with the seizures, or is this something that's more chronic? And if it is, we really want to help our patients by treating the depression, referring them to psychotherapy, referring them to epilepsy support groups. I will state that I wanted to put some information for the local epilepsy support groups up here, but I think when the Epilepsy Foundation Northwest's website switched over to the parent Epilepsy Foundation website, some of that link got lost somewhere, and so I was unable to provide that for you, but hopefully we can get that fixed at some point. And then also considering psychotropic medications like antidepressants or kind of anti-anxiety medication. Another valuable resource is the Managing Epilepsy Well network, and you can just Google this, and they provide you with different names of places that have these structured programs that actually help patients learn self-management skills to help manage their epilepsy, and by doing that, kind of help with things like memory, quality of life, and mood as well. So, and these are some of the different things, some of the different programs that are out there, and PACES is actually one that was created here at the University of Washington. I also want to touch briefly on post-ictal psychosis, because it does impact our patients, impacts about 6 to 10% of patients with epilepsy. And these symptoms typically occur within about 7 days of a seizure or a cluster of seizures. And typically it's within the first day to 3 days after a seizure. Someone who experiences post-ictal psychosis doesn't really have these psychotic symptoms at other times in their life. It's really right after they do have a seizure. It's most common after having a convulsive event. And also there's research to suggest that when post-ictally someone has insomnia, that's often a first sign that someone may go on to develop a post-ictal psychosis. So it's been recommended that if you see this insomnia, that consider treating, kind of preemptively treating for a post-ictal psychosis, and they will be less likely to go on to developing a post-ictal psychosis. The symptoms can last for several hours to several months. Several months is a long time, but there's good news because these symptoms can be pretty well treated with benzodiazepines or antipsychotics. And so what does a post-ictal psychosis look like? The general psychotic symptoms are delusions, so having these fixed beliefs that something is going on that cannot be changed. Despite having evidence, so thinking that, the government is tapping your house, wiretapping your house, someone's watching you, and family members will be like, it's not happening, look here, there are no wires anywhere, but still continuing to think that. Having hallucinations, and that can be auditory, visual, or tactile. So hearing, seeing, or feeling things that aren't really there. Having disorganized thinking, and so this is kind of having thoughts that are tangential, kind of jumping back and forth between different topics, being really disorganized. Their speech can be disorganized or incoherent. Having this grossly disorganized or abnormal motor behavior, and this can look like childlike silliness behaviors. It can look kind of like erratic behaviors as well. Or patients can actually be catatonic, where they just kind of stop moving and stay still for long, long periods of time. Patients may also have negative symptoms, which means like a lack of kind of emotional expression, speech, lack of speech, kind of lack of pleasure in things that they used to enjoy. And then last, I just wanted to touch on psychogenic non-epileptic seizures, because these do exist. These are things that look like seizures, but they are not associated with any sort of electrical activity in the brain on EEG. The cause is considered to be psychological. A lot of times the patients will have a significant level of distress in their life, or they may have some sort of history of trauma that occurred. It's suggested that about 20 to 30% of patients who are actually referred to epilepsy centers have PNES versus epilepsy. But we should also note that individuals who have epilepsy, who have these electrographic changes on EEG, can also have comorbid PNES as well. So they may have a dual diagnosis. The anti-seizure medications that we use to treat patients with epilepsy do not actually stop the PNES events. And so if they have a single diagnosis of PNES versus a dual diagnosis, usually we take them off of these anti-seizure medications, and then really try and treat them with psychotherapy or antidepressants. But there is also growing popularity of these workbooks created by Dr. Kurt LaFrance from Brown. And it's kind of a workbook that a therapist will go through with a patient week after week that kind of helps them get better control under the NES events. So in summary, as expected, depression and anxiety are really common in epilepsy, and there are numerous factors that can kind of lead to someone having epilepsy, with a reduced quality of life being a significant contributing factor. I didn't put this up there, but I should just note that, like we talked about, risk of suicide is high in our epilepsy population. And so when we do see these symptoms, it's really important that we identify them and try and get patients treated. And then also remembering that these postictal psychosis phases can occur in our patients, and those should also be treated relatively quickly, and that patients can actually have PNES instead of epilepsy, or they can potentially have a dual diagnosis. All right, any questions?
Got one from the stream. Under postictal psychosis, would all of the examples of behaviors need to be present, or could any one or combination indicate postictal psychosis?
Good question. No, they do not all have to be present. They can just have one of those things. Yeah.
All right, got one right here.
If the symptoms are very rare, like, I'm a caregiver and my team will sometimes say I'm feeling really sad, but it's just once or twice a year, is that just...
I think
do they
that's
grow out
pretty
of that?
common,
Okay.
and I think that's where, where they talked about the dysthymic disorder due to kind of epilepsy was kind of brought up, because a lot of our patients do report feeling sad here and there. Unfortunately, a lot of patients have been living with epilepsy for a long time, and it's been chronic, so they've kind of learned how to deal with it, and kind of have some of our patients have a really positive outlook and have, little periods here and there where they feel down. It would really need to be having those symptoms for every day, all day long for at least 2 weeks to be diagnosed with a major depressive disorder.
Okay.
Yeah.
And a quick follow-up question, which is slightly tangential, but I've got the teen that I have also, the driving license was really important.
Sure.
But also, she doesn't want to wear a ID or put a seizure action plan in her dorm room and things like that.
Right.
Any tips and tricks on how, is that something they'll grow out of, or is there a way?
I think it depends on the individual. Some people are a little bit more stubborn than others, right? What I do see is that oftentimes if the seizures continue, people do kind of grow out of that, they start taking care of their own health. Comes with kind of growing up, I think, sometimes, but I understand your teen, it's hard, right? They want to have the same type of life as their friends and not have the restrictions that they have. So that's hard. Yeah.
If someone develops post-ictal psychosis, what can a caregiver do to help them?
Contact
Especially if
their
they're
provider
not-
right away. Contact their provider right away so that they can get treated. Yeah. You could potentially go to the ER for that, but yeah, I would say getting them seen as soon as possible.
So I'm wondering, you had mentioned that sometimes postictal insomnia sort of heralds the potential incoming postictal psychosis. If you suspect that somebody is going to develop postictal psychosis but hasn't yet,
Right.
is there anything that you can do to avert it?
So the research, again, I'm not a medical doctor, so I'm gonna, put that out there. But the research does suggest that prescribing risperidone early on, once you see the insomnia, could potentially stop them from going on to developing the postictal psychosis.
Thank you.
Yeah.
If someone is going to see a therapist for help with some of these disorders, do you think it makes a big difference if that provider is, regularly treating someone with epilepsy or,
Yeah.
specializes in that?
Yeah, that is a really hard thing. So I deal with this a lot with my patients. They will go to a therapist and they're like, my therapist just doesn't understand epilepsy and all the things that are, that play a role in my depression. Some therapists are better than others and may not have that experience. I think it's most important that you find someone that you can build a good rapport with and that you can connect with. And if you do feel like having someone that has that epilepsy knowledge is really important for you, I think going out and finding someone that does have that knowledge would be beneficial. And there are providers out there. And hopefully your epilepsy center, your local epilepsy center could point you to providers that could provide you with that type of therapy. Yeah, but again, I don't think it's necessary for everyone. But I do have a subset of patients who say that that's ultimately been the most helpful for them.
Hi, thank you for your talk. I had a question or clarification about the part where you're talking about anxiety and the hippocampus and temporal lobe epilepsy. So if you have auras where you feel intense like fear and anxiety, were you saying that you'd be more prone to developing anxiety or?
So the research suggests that the same areas are kind of implicated in like if you have a temporal lobe, that's where the onset is in those mesiotemporal structures, right? So what I was trying to say is that there's this kind of overlap of the structures that are kind of implicated in both of those. But we do see that anxiety response with patients who have temporal lobe epilepsy and possibly because of the structures that are being impacted. Yeah.
And then my other question was, do you know if there's any literature on the impact of meditation and anxiety in epilepsy?
Not specifically meditation. I'm sure that literature is out there though, and I'm sure that it can be helpful because I know that there are a lot of patients who say that anxiety can kind of trigger their seizures. So I think doing anything to help kind of suppress some of that anxiety or get it under better control is probably a good thing, right?
Thank you.
Mm-hmm.